one video on prevention of bloodstream infections associated with central venous catheter. This is based on the WHO guidelines, which were being published in 2026 and their recommendations. As we all know that clabsi is a threat or a problem which are faced in the critical healthcare setup, which adds on almost $46,000 of cost per case and 44.6 per thousand line days. CLABSI rates are reported in some of the low middle income countries. CLABSI has been among the most preventable healthcare associated infection, yet it drives significant patient morbidity, mortality, and increased hospital stay. In US ICUs, the rate is 0.8 per thousand central line days, but in low and middle income countries, rates can go up to 56 times higher. COVID-19 further worsened CLABSI rates globally. Only 6% of the countries meet all WHO minimal IPC requirements. What is the purpose and the scope? My purpose of doing is for the short and long-term CVCs in the adults, adolescent and children and neonates. What are to be included? I have excluded the hemodialysis catheter, and catheter types may be non-tunneled CVCs, tunneled CVCs, and totally implantable venous catheters known as portacaps. Targeted audience are clinicians, IPC professionals, hospital administrators, patients involved in the CVC management itself. So guidelines were developed by the steering group using the systematic reviews and the evidences, and education prior to insertion is mandatory. Recommendation is that pre-insertion body wash. WHO suggests daily chlorhexidine containing body wash, liquids or wipes in critically ill adults, adolescents, and children. This is a conditional recommendations. Although minded, not recommended for neonates due to risk of chemical burns, particularly beneficial in high CLABSI rate settings or low middle income countries. Now, education and training is continuously needed. Hand hygiene, train your clinicians in WHO multimodal hand hygiene strategies. Please perform hand hygiene at all 5 moments during the CVC insertion, maintenance, assess, replacement, and removal. Insertion, sterile techniques, and skin disinfections are needed. Now, again, the recommendation says that preferred antiseptic solution is alcohol-based. The preferred antiseptic is the alcohol-based solutions. These are the alcohol-based chlorhexidine 1 or 2% over alcohol, iodine, or alcohol alone for skin disinfection. So the preferred antiseptic is alcohol-based chlorhexidine. You have to have a alcohol-based chlorhexidine solution 1 to 2%. Use sterile single use. Don't use clean gloves. Use sterile single use gloves. Maximal sterile barrier precautions while insertion. Again, cap, mask, sterile gown, gloves, full body drapes at insertion. This is a conditional recommendation. Skin disinfection. Always disinfect skin before insertion. Prefer alcohol-based formulations. Now, standardized insertion packs. Use standardized pre-packed kits which are available for all CVC insertions in all populations. Now, again, there is a recommendation. There is no recommendation on ultrasound guided insertion for infection prevention. So mind it. Do not confuse itself that ultrasound guided insertion is not recommended. The ultrasound guided insertion versus blind insertion, there was no evidence of infection prevention or lower infection rates. These were found, but although ultrasound is recommended for reduction in the pneumothorax risk. So this was what was the recommended for these settings. Then coming to the dressings which are to be used at the CVC site. Now the dressings which are to be used, again, just a minute, I'll just clean it up, the lines, and then I'll continue with the lecture. Yeah, so recommendation 5 is dressing type. Which type of dressing you need to use? Use either transparent, semi-permeable, or gauze dressings after CVC insertion. Transparent dressings allow site inspection, gauze absorbs moisture and exudate. Conditional recommendation. Again, so dressing type, use transparent, semi-permeable, or gauze dressing after CVC insertion. Transparent dressing allows site inspection. So transparent, it should be transparent. Antiseptic patch or dressing. Use an antiseptic patch or dressing. Example, chlorhexidine gluconate impregnated sponge at the CVC insertion site in adults, adolescents, and children. Conditional recommendations. Now again for neonates, prioritize basic IPC measures before antiseptic dressings in the resource limited settings. So chlorhexidine again not recommended for neonates. Maintenance dressings, flushings, and tubing. Recommendation says that use a formal dressing change schedule. Change interval every 3 days or more, not shorter. Change immediately if dressing is soiled. If it is visibly soiled or disrupted, change it immediately. If not, then change at least after 3 days. Again, the recommendation regarding the infusions type, if you are using infusion sets, IV infusions, either continuous or intermittent IV is acceptable for CVC maintenance. Choice depends on clinical setting and patient condition. If prefer sterile saline, whenever you are using something for flushing the uh, line, prefer sterile saline over heparinized saline for lock-off flushing. Always flush with compatible sterile fluid after product administration. Now, if you are using IV sets, then change tubings every 7 days for routine IV fluids. Simply IV fluids or crystalloids you are using, change it after every 7 days. Change after, if you are using TPN or lipid products, then within 24 hours. You have to change it within 24 hours. So this is the recommendation for administration set changes. Dressing changes every third day. Administration set changes, change tubing every 7 days for routine IV fluids. Change administration TPN if TPN or lipid products are being infused through the IV sets. Change it within 24 hours. Flushing, use sterile saline over heparinized saline. Infusion type, either continuous or intermittent is acceptable for CVC maintenance. Now assess replacement and removal. Always use aseptic technique to assess CVC. Either closed access or open access subsystem is acceptable. Closed access reduces needle stick injuries but carries a very high cost. Now replacement and removal, inspect the insertion site at least daily for signs of inflammation or infection. Promptly remove any CVC no longer essential for patient. Always daily assess whether the patient needs CVC or not. If not, remove it. If it is inflamed, infected, then again change it. Do not adopt a practice of routinely replacing a CVC unless clinically indicated. Routine replacement increases mechanical complication risks and added cost to the patient. Now, site catheter selection, again important. Recommendation says that prefer subclavian over jugular and jugular over femoral. Subclavian is the preferred site over jugular when no contraindication exists. Now, catheter coatings, antibiotic impregnated CVC, either impregnated or non-impregnated acceptable, reserved for high-risk patients. Antimicrobial resistance is again a concern. Antiseptic coated CVCs suggested for use, especially in immunocompromised or high-risk patient, and maximum 21 days. So antiseptic coated CVCs can be used. Antibiotic impregnated CVC only in high-risk patients. Facilities with high clabsi rate should first optimize compliance and other recommendations before adopting two antibiotic coated catheters. So again, preferred site subclavian, second choice jugular, antiseptic coated, preferred, antibiotic impregnated in high-risk patients. Long-term catheters, lumen number. Prefer to use a single lumen catheter over multi-lumen catheter for long-term use. Each lumen is a potential pathway for entrance of an infection intraluminally or extraluminally. Hickman versus Portacath. Either a Hickman CVC or a Portacath is acceptable for long-term access. Decision should be based on the clinical need and patient preferences. Hickman lines, external lumen, easier access, suitable for continuous or frequent IV therapies, TPN or long-term antibiotics. Portacath, fully implanted, more discreet, preferred for intermittent treatment, example chemotherapy, and can remain for years. So this decision lies on the clinical needs. Again, other preventive measures, CVC securement. There are sets which are available having sutureless device or a suture-based securement. Either of the two, there is no evidence that suture increases the infection risk. Then coming to the antimicrobial log, some microbiologists recommend that just insert vancomycin and or any antibiotic and log the CVC. Do not use antimicrobial log solutions for short-term CVCs. Toxicities, antimicrobial resistance again is a concern. Antiseptic line caps. Yes, either antiseptic impregnated or non-impregnated line caps are acceptable. Now, prophylactic antibiotics. Do not use IV prophylactic antibiotics at line insertions. Risk of antimicrobial resistance, C. diff, adverse events, all are there. Surveillance. Perform hospital acquired infection surveillance, including clabsi, AMR detection, establish national network, hospital network, timely data feedback. Care bundles. Again, set of 3 to 5 evidence-based interventions implement collectively for greater impact. So follow care bundles. WHO multimodal improvement strategy says that implementing all CVC infection prevention interventions through multimodal approach. Interrupted time series studies consequently shows clabsi rate reduction following MMIS implementation up to 78% reduction in one study. So build it, teach it, check it, sell it, live it. Key takeaway points are train, assess, optimize insertion, maintain vigilantly, remove promptly, implement via MMIS, deploy all interventions through WHO multimodal strategies. Thanks. I'll stop sharing.